Hi, listeners. I'm Lauren Mackler, CEO and co-founder of Co-Fertility, where we help women freeze their eggs for free when they donate half of the eggs retrieved to a family that otherwise can't conceive, making egg freezing more accessible and egg donation less transactional at the same time. To learn more about how Co-Fertility is making fertility care more ethical and human-centered for everyone involved, and to see our open roles, visit cofertility.com.
Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. As digital health and AI tools scale rapidly, how do we ensure fair, useful evaluation standards? Ones that protect patients without holding back good ideas. Today, we have a special episode on this topic to explore what evidence matters, how we communicate it, and how to build public trust at a time when both science and innovation are under pressure. We have a special guest host today, our friend Lucia Savage, who is a board member of AcademyHealth and the Chief Privacy and Regulatory Officer at Omada Health. She is talking to Dr. Aaron Carroll, CEO of AcademyHealth, and Dr. Vindell Washington, Chief Clinical Officer and Head of Health Equity at Verily. I hope you enjoy the show.
Welcome, Aaron and Vindell and all of our listeners. I'm Lucia Savage, and today we're going to tackle the intersection of evidence and innovation in healthcare. It's great to spend some time with you again, Vindell, since our ONC days, and on the important topics that are near and dear to my heart, a learning health system and innovation supported by digital technology. So let's get right into it. I think here we would all agree that the evidence that a certain protocol works is important. But from my digital health seat, I see that there may be skepticism of healthcare delivered through digital tools or asynchronously than traditional care. Or we may have some assumptions about traditional care that we haven't tested in a while or comparatively. What must buyers and regulators see to place their trust in the efficacy of digital health tools? And how is that different from traditional care? And what else should we be thinking about with the accelerated pace of integrating AI into technology? Vindell, what do you think?
Well, I'm super happy that you framed the question, Lucia, around the new horizon versus traditional medicine. I think we're maybe some 175 years into what we would term modern medicine, and we haven't necessarily tested or stripped out, for example, elements of traditional medicine that have not gone through rigorous randomized controlled trial aspects of care. And so although I'm very much in favor and would encourage those who are adopting digital tools to make sure that those tools have been tested in some rigorous way, I would point out that sometimes the exact comparator is somewhat difficult because there is a bit of art of medicine that has been around and not as rigorously sort of addressed over the period of time. So yes, we should have that right framework. And yes, it will be in some ways different than what we've done across the House of Medicine over the course of time. I would say one thing that makes us particularly at a great time for that kind of work in digital medicine is just the sheer amount of data and technology allows us to do the kind of analysis, often in real time or close to real time, that helps us ensure that those who are using tools that are great tools. So I think we should have the same kind of rigor. And, we at Verily do have a framework that allows us to think about what I would call standard reporting. But I'm also talking about monitoring and addressing issues that come up in the course of the deployment. And then one additional aspect that I'll just point out, and I think it's even newer than this concept of just digital medicine generally. I think it's this category of artificial intelligence that is really generative in its nature. And I think the one thing that I would call out that's different in the way that we should both evaluate that activity as well as ensure that over the course of time it's performing as expected is that we have to recognize that by its very nature, a generative AI digital solution is not the same kind of medical device that we have thought about deeply over the past 15 or 20 years. That kind of medical device, for example, may not give you the exact same answer that one received from a question that was posed even a day or two earlier, because our expectation with generative tools is that they're going to improve over the course of time. And what we're trying to do there is much more in the way you expect a live practitioner to change their practice over the time as it learns and grows. We need to think about frameworks that aren't static in the way they look at the performance of those tools. So there will be elements that fit the frameworks that you and I, Lucia, and others sort of thought about in our ONC days, where we were thinking about how should you measure software as a medical device in a more static position, but we also need to think about the new horizon.
It's interesting because it's also true that like a human may not produce the exact same result every single day when presented with the same
Absolutely.
facts. Humans are generative kind of by their very nature.
Exactly. Yeah, we're their initial generative intelligence, I guess.
That's right. Aaron, what do you think? Is Vindell right?
Oh, well, I think he is. I think it's an important and very complicated question. You know, I think usually when we think about how do we validate a new thing in medicine, we're usually talking about a drug, we're usually talking about a device, we're usually even talking about a small intervention where you can quite clearly say, like, this is the outcome we expect. Are we getting that outcome? And, what are the downsides that come with getting that outcome? Part of the problem with digital tools and how they are different, and especially when we talk about AI, is we're not talking about, a simple intervention that should have a very predictable result. We're talking about almost sometimes replacing a clinician or managing care in ways that aren't very well explicitly defined right ahead of time with a very explicit outcome. That makes it very complicated. Because it's very different to say, well, if I give this drug, I expect this to happen, to say, well, if I use these digital tools and they're managing complex care, what are we looking for? Are we looking for better health? Are we looking for more streamlined access? It's complicated. And if you're talking especially about replacing a person or replacing a clinician in that type of environment, it's really difficult to measure. That said, I think it's important that we do it. But I also think you bring up a very important point that we trust traditional medicine in ways that we've never really studied or validated in the past. So few of our interventions are actually studied by randomized controlled trial. The vast majority of them obviously are going to be drugs or perhaps devices. But what actually happens in an office room, or what actually happens as people's care is managed at home or distance is I don't love to say it's art and not science, because you hope that science is still involved, but it's not well studied. We don't know how it works. We obviously don't have a ton of replication in the sense that we know that every clinician manages every problem with the exact same way, that we would get that kind of consistency. So we do make assumptions about traditional care that it's okay and that it's good because of the ways that we've either qualified clinicians to practice or the ways that we've tested them in the past. But clearly that's suboptimal as well. So as I think new tools come along, especially new digital tools, we're just going to need to make sure that there's transparency, that there's validation, that there's good evidence of safety and efficacy, and some accountability for outcomes. And we need to keep checking that over time, because these tools do change all the time. But it probably calls into practice the fact that we could be doing a better job of doing the same for traditional care as well.
It's interesting because, from where I sit, I think the idea of replacing professionals is definitely kind of on the horizon line with generative AI, but the vast majority of digital tools that I'm aware of actually just make regular professionals smarter, better, faster, more efficient using traditional protocols. And so I think it's important to ground the conversation in quantity, right? At this moment in 2025, we talk about AI all the time, but actually what's really happening in people's lives is mostly not AI.
Yeah, and when we're talking about, advising or giving information to clinicians to help, or even to patients to help them do a better job, well, that's where it's interesting in that I think that there's a reasonable argument to be made, or pushing back, that there doesn't need to be perhaps as much regulation. I mean, doctors can use books off the shelf. They can use Google. They can use asking a friend, all kinds of stuff all the time that they don't necessarily have to validate by randomized controlled trial ahead of time, because we trust that clinicians will take the information and make good decisions wherever that information is coming from. And so that's different. And there's an interesting, I think, discussion and argument to be made around how much study do we actually need if we're still letting the final decision be made by a human being?
Or if it's a standard protocol that is just being delivered with different communication. Well, that takes me right to the patient. And I know, you're both physicians. I'm not a physician, but most of the physicians I know, and I would put you two in that category, like, you're basically here to help the patients. That's the goal. That's why you do what you do. So when we think about the voices of the patients, and that's the gamut from, somebody's 80-year-old grandmother who, in fact, according to Pew, may be using a smartphone every day, to the post-millennial kid, 9-year-old right now. How do we integrate the voice of the patient into our assessment of digital tools, into building that body of evidence about what works and what doesn't work? Vindell, what do you think?
I think it's an important question. I think the answer can be somewhat multifactorial. I think that there's work that absolutely needs to be done in the design phase of the tools that we bring to the market. I think the sort of idea of how you design not just for a technical clinical outcome, but that you're actually designing to make sure that patients feel heard, that the interactions demonstrate that you have some cultural competency, that a person feels a degree of trust in the interaction. And so one of the things that we've done that I'm proud about, but I think about like even ways that we can continue to push that forward, is this concept of a design partner in the frame of an advisory panel. So it's not just whether or not doctors and nurses think this is the right thing to deliver, but what is the interaction with patients? If they, for example, are talking with a generative AI agent, does that interaction make them feel heard? Do they feel like it's cold and distant? And those are really important frameworks. And, I think even, Lucia, when you and I were working together, this sort of concept of patient-reported outcomes, and that the value of a clinical intervention may not be, for example, in just the number of points that a hemoglobin A1C was reduced, but maybe how that person was able to live a better life, or whether or not they were able to meet their personal goals. I think that kind of humility when it comes to whether or not interventions are good interventions or not. And I will tell you that in many areas, particularly as a clinician who's carried a stethoscope around for many years and really believed in the healing touch, I think that there are areas where you'll have for example, an advisory board that says their interaction with an AI agent was intimate. Because, for example, unlike their doctor, maybe the AI agent does remember things from 6 years ago that was mentioned in passing. Maybe that there's some consistency there. Maybe the tone is consistent and it isn't like Washington when he's only had 4 hours of sleep when he needs 6 hours of sleep. That agent may be acting in a different way. And so my big sort of push in that is to just continue to have our eyes and ears open to the feedback we're getting from patients, and don't be so regimented on what is the single one or two technical clinical outcomes that are the measures of success. I think that broader lens is appropriate and necessary in helping people.
Erin, I mean, you lead an organization whose membership does health services research, applied healthcare research. How are you and your members thinking about the patient's perspective when you're looking at whether something works or not? And then I have a follow-up question about tech versus healthcare processes.
I mean, ideally, patient perspectives should be incorporated at all levels of designing, evaluating, and even adapting new technologies. I'd argue that that would be true even if we were talking about traditional medicine. And, meaningful patient input has to occur at many different stages, from need identification to user design, clinical validation, continuous monitoring of outcomes and experiences after things have been launched and used for some time. I think the good news is that digital health development often naturally emphasizes many of these things, including usability, engagement, addressing real-world patient barriers, the barriers that patients might encounter. Traditional care sometimes undervalues the patient experience outside of the clinical setting. We put most of our focus in a very specific sort of interaction between the clinical environment and the patient. But, digital health offers critical insights around preferred communication channels, accessibility, ease of use, and patient-defined meaningful outcomes. And there's been a push, I think, in the last decade to focus more on patient-centered outcomes, but too often we just miss the boat there. And I think that there's a real opportunity with many digital health tools to, as I talked about before, to really think about what are the outcomes that we're looking for? What are the specific things that we'd like to see? And I think a lot of those could be better defined by patients and recognize that the patients might want different things than we often think about in the clinical environment. And digital tools often provide a real way to both capture those, but also for us to learn about what might patients value more.
Can I piggyback, Lucia, onto Aaron's comment? I think one of the things that's interesting to me as well is that often the problem with traditional medicine is just that, it's traditional. And so the design that it sort of grew up in and the changes over time have often been made to maximize, for example, the efficiency of the doctor in that system and not necessarily looking at it from the patient perspective. So I guess I'll put a 2+ signs behind Aaron's comment that the one positive framework that sort of stands out head and shoulders above in many of these digital concepts is that you start with what is the thing that makes the patient's life easier, what's the thing that's the stickiest part of the tool that makes them likely to do the thing that's hard to do. I think that is a healthy framework, and it can be, as Aaron was alluding to, it actually can be brought into how we design traditional care delivery systems. But I think in some ways it's harder because in this new world, you're having a little bit more of a blank slate, as opposed to saying, how do I change the clinic down the street that was, founded in 1950 something? How do I make that thing function differently today?
Yeah, it's one of my big learnings in coming from sort of a traditional setting, government and big insurance company to Omada was how fast the feedback loop actually operates with even something as simple as a thumbs up, thumbs down on a feature in your app.
Yeah.
I can't remember the last time I saw thumbs up, thumbs down on my physician's my health systems in my chart instance, but I sure would like one. And also they could ask me about whether the parking costs too much. But so Aaron, I guess my follow-up question for you is that something that your members as they research health services are really thinking about the different ways in which old and new account for the voice of the patient? Or is that something that we need to think about more maybe?
I think it's an and. I think that, yes, probably health services researchers spend more time than many other types of researchers focused on patient-centered outcomes and thinking about how do we really improve the patient experience and patient life, because that is part of, I think, access, and it's also part of quality in terms of outcomes. But we also could do a much better job. I think that even still, when we talk about patient-centered outcomes and we focus on them, they are still too often defined by the healthcare system and not necessarily really engaging patients as deeply and as often as we should in order to make sure that we're actually measuring what matters to them. It's hard and it's slow and it's expensive and it sort of upends the very traditional research methods that we use. But it's probably necessary if we're going to really talk about improving health in the ways that truly matter to people, and getting out of that very sort of clinical, rigorous, office-based mindset, looking for clinical outcomes and recognizing that other things actually matter to people, and that's what they're shooting for. It's a necessary change that we have to keep moving towards.
Great. All right, I'm going to talk about innovators a little bit. I'm going to try and weave some outcomes in there. And you guys know we did some prep, but I'm meandering a little bit. So, Vindell works for a digital health company. So do I. I think Aaron has pretty broad exposure. But we also are at this moment in time where there's ever increasing skepticism about science. Evidence is oftentimes produced in meaningful ways that are reliable and replicable, and other times it just kind of is not. So what are the roles of the people who are innovators themselves or advocates for innovators in making sure that we're generating reliable evidence, and in particular in creating evidence such that outsiders, buyers, regulators, whoever can see traditional and digital health in as much of an apples to apples comparison as it's possible to generate? They are different things, but they have many similarities. So what should innovators be doing? What should be their North Star and their processes for that? Do you want to take a stab at that, Aaron?
Sure. I think, innovators probably they do. They have a crucial responsibility, not just to create new products or technologies, but to continuously and transparently gather evidence validates that innovation's real world value. But the most important thing is that they have to articulate that these solutions work, but they also have to show how they work, why they work, and for whom they work. Communication is key. And I think that this is where we sometimes drop the ball. And I think it's also important to understand that communication with different stakeholders probably needs to be tailored for that environment. Patients are going to need to understand and hear about concrete outcomes and experiences. Messages have to be relatable. They have to be focused on meaningful personal benefits. A healthcare professional, on the other hand, is going to be much more concerned about clinical efficacy and safety data, ease of integration into the workflow, and obviously also real-world improvements in patient care. A buyer or a payer is going to be a little more concerned about cost, value, efficiency, scalability, measurable returns on investment. Regulators are going to need to hear about clear, transparent, detailed methodologies, rigorous validation evidence, processes for ongoing monitoring and accountability. Trust is more than good intentions. It really demands that innovators openly acknowledge limitations, unknowns, areas for improvement, potential biases, and a transparent path towards continual improvement and accountability. And ultimately, reinforcing that kind of trust publicly demands active engagement in forums, peer-reviewed publications, evidence sharing, and a real willing to collaborate to set standards that ensure ongoing patient and community trust in innovative digital health and eventually AI solutions. It requires using a skill set that I think too often, certainly scientists and innovators don't focus on. You get too focused on the technology and not enough on the human interaction and how we all need to be able to understand exactly how these things are being used. But that communication is going to be key if we're going to have the trust and accountability that are necessary to make all of these things work.
So Vindell, you've been both a regulator that people explain things to, and now a proponent, an advocate for your digital health company. How would you add anything to what Aaron has said?
Well, I love the framing that Aaron put forward. I think I was sort of contemplating the last couple of comments he made about the transparency aspect of the work, which is one of the threads that runs through each of those, the frames that he laid out. And part of that transparency, the one good thing about having been in a modern medicine era for 175 years is we actually have gotten pretty good at knowing the kind of evidence that you want, that it needs to be reproducible, that it needs to be transparent, that it needs to be scientific in the way that it lays its outcomes and prospective outcomes and how it tests. And the fact that you need to be specific enough as you talk about how you've measured and gathered your evidence so that others can reproduce those kinds of outcomes and settings as they go forward. And so there's a transparency aspect, I think, that's just critical in that, and I think it would be wrong to abandon that component. I think the ad that I love in Aaron's comment is that other audiences might be measuring for different things. You can still use similar methodologies, and there's great methodology around usability and other what I would call softer aspects of this work. And then having worked at an insurance company for a stretch of time, they're extraordinarily good at making sure that they're measuring value, cost over time. They know how to do run out after claims have come through to make sure that dimes and pennies are not missed when they're doing their calculations. My opinion is that the systems of measurement in the future need to address each of those frames that Aaron put out. And I think there needs to be more transparency over the course of time, which allows those who are doing good work to be recognized as doing that good work. It's not the time to be hyper proprietary about the outcomes. I'm fine if you want to sort of have some secret sauce in the way that you do your work behind the scenes, but transparency and the outcomes and measurement and the ability to be measured, I think it's actually going to be an asset to companies that embrace that work.
I wish we could keep this going, but I know we're on the clock, and I want to wrap up first by saying thank you to the Heart of Healthcare team for letting us, passing the mic and letting us sub in today. And then I wanted to thank Aaron and Vindell for their invaluable insights. Obviously, this is just the beginning of a conversation on this vital topic that has been kind of occurring quietly for the last couple of years. Today, we spoke about developing a common language for healthcare professionals, researchers, payers, developers, and the voice of the patient in how we assess healthcare, whether digital or traditional. And there'll be a lot more dialogue coming up at Academy Health's annual Health Data Palooza this year on September 5th. The Data Palooza provides a collaborative and energetic space for the tech industry stakeholders to speak directly with patients, health system leaders, policymakers, and health services researchers about these critical issues and more. So we invite you, all of the Heart of Healthcare listeners, to join us at the upcoming Health Data Palooza in Washington, D.C. on September 5th. You can visit academyhealth.org/datapalooza to learn more. We look forward to seeing you there and continuing this essential dialogue and hearing what you think about evidence and on the efficacy of digital health tools. So thank you again, Vindell and Aaron. Any closing words from you?
I would just reiterate what you said. I think that these kinds of conversations are critical. Getting all of the perspectives in the room is hard, but Datapalooza does that well. I'm looking forward to it, and I hope many people can join us on September 5th.
Yeah, just thanks, Lucia, for your moderation here, and Aaron for allowing me to share this time with you and the listeners. And I'm excited about the upcoming events that you've described, Lucia.
Great. Well, we'll see you all in September, and I hope you enjoy this episode.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.